So, Bismillahirrahmanirrahim. Good morning and Assalamu alaikum dear students. Hope everything is fine with you and your families. May Allah forgive and bless us. Today topic for discussion is hypertensive retinopathy, which is actually is the ocular manifestation of systemic hypertension. Ocular effects of hypertension are seen in retina, choroid, and optic nerve. It causes transient and permanent microvascular damage. There is narrowing of the retinal arterioles. Pure hypertensive narrowing is seen in young adults because the process of involutional sclerosis is going on in all the people with age. So when you see an area of focal narrowing, and that we actually see in young patients, like see in these pictures, these are the normal vessels, but this area there is focal narrowing. So this is actually seen in young patients. In older patients, the vessels are getting narrower with age. So there is worsening of the arteriolar sclerosis, and but overall there is, so this is a process of hypertensive changes is superimposed actually on the process of involutional sclerosis. So this picture is seen in the young adults, and there is disruption of the inner blood retinal barrier along with the arteriolar sclerosis. So there are two manifestations basically. There is arteriolar sclerosis and there is disruption of the inner blood retinal barrier. As I told you earlier, focal or generalized arteriolar narrowing is associated with there is generalized and focal arterial narrowing, and this is associated with increased risk of coronary artery disease. So actually by diagnosing this kind of retinal features, you are the one sometimes who is going to refer the patient to the internist for the management of hypertension. So this is one of the feature, as I told you earlier, focal or generalized arteriolar narrowing. Second features associated with the severe hypertension is cotton wool spots, along with the increased permeability due to the disruption of the blood retinal barrier. This is a sign of ischemia, definitely cotton wool spots. These are the cotton wool spots. These are the cotton wool spots. You see, this is also cotton wool spots. These are the hard exudates. This picture is of hard exudates. The hard exudates are more yellowish in color and they are well demarcated. These are whitish in color relatively and they are not well demarcated. These are like fluffy in shapes, like a cotton. And here we can see some disc edema also. This is a picture of malignant hypertension actually. So in continuation with the clinical features of hypertensive retinopathy, there is disruption of the inner blood retinal barrier in sustained hypertension, as I told you earlier, and that leads to the increased vascular permeability. This is the same picture again. Here again we can see the cotton wool spots. See, there's altered retinal reflex also. It's not normal pinkish or yellowish pink color. It is relatively whitish color. So this is all edema. See, this is edema. This is peripapillary edema. If you compare this area with this area is edematous because of the leakage or increased vascular permeability. The features associated with permeability is flame-shaped hemorrhages, retinal edema. As I told you earlier, there are hard exudates around the fovea. This is very characteristic. The hard exudates around the fovea, because I think this is the outer plexiform layer has got a space there, and so this increased leakage in that layer, outer plexiform layer, and there is optic disc swelling. These are all features which are associated with increased vascular permeability, increased capillary leakage due to the sustained hypertension. There is disruption of the inner retinal barrier. The second important thing, or rather the first important thing, is arteriosclerosis. So keep in mind all the changes which we see in hypertensive retinopathy, they are associated with arteriosclerosis and increased capillary leakage or increased vascular permeability. What are the histological features of arteriosclerosis? There is intimal hyalinization, there is focal, there is endothelial hyperplasia. I mean, there is hyalinization of the inner layer, intima, and there is endothelial hyperplasia, and there is hypertrophy of the media, the medial layer of the arterioles or the vessels or the arteries. And the most important sign of the arteriosclerosis is AV nipping, or AV nicking. See here, these arteries, we can see the sclerosed thickened artery, and they are crossing the veins, and they causing nipping or nicking. Sometimes it's written nicking also. They nick because they share the common adventitial sheath, so they compress the veins. This is known as AV nipping. And this one, all sometimes people say that this is the grading of hypertensive retinopathy. No, this is actually grading for the arteriosclerosis. This one, it's not purely, because hypertension causes not only arteriosclerosis, it also causes disruption of the inner retinal barrier, leading to the hemorrhages, hard exudates, retinal edema, and so this is the grading of arteriosclerosis. So it has got, we have got, these are the normal vessels, as we can see here, the normal caliber, the normal looking retina. But here we see there is, because of the sclerosis, there is broadening of the arteriolar light reflex, and because of the sclerosis, and there is also arteriolar attenuation. This words is sometimes confusing. What is vein concealment? Actually, because of the sclerosis of the arterioles, their reflex is broadened. There is broadening of the reflex, and this broadening of the reflex actually, that conceals the vein reflex. So the veins are not that prominent as we see in the normal retina. The arteries become more prominent. This is the meaning of vein concealment. So because of the broadening of the arterial light reflex, this causes veins. The veins go under a shadow, something like that. In the second grade, so if in the first grade we see subtle broadening of the arteriolar light reflex, and there is arteriolar attenuation, as I told you earlier. It's more marked in younger patients, but in older patients you have to be very vigilant to look for these signs. They are not very prominent, and you need to see in a very keen manner the retina to find out these signs. The second grade of arteriosclerosis is deflection of the veins at the AV crossings. This is known as Salus sign. See, the veins are deflected at the AV crossings at right angle. This vein was not going straight, it is deflected at right angle at the level of the AV crossings. See, the arteries crosses the vein. The third one grade is the copper wiring. Copper wiring of the arterioles is actually the early sclerosis of the arterioles that leads to the change in the color of the arterioles, and this is known as copper wiring. And then third one is banking of the veins distal to the AV crossing. This is known as bonnet sign. See, this is banking. There is over dilatation of the veins, the collection of the blood. This area is more dilated. So banking of the vein distal to the AV crossing. This one. and this is known as bonnet signs. And the third one is gun sign, tapering of the veins. The veins are tapered, you know, along with the crossings. Here we see there is more dilated blood vessels, dilated vein, but close to the arterioles. You know, this is like a pen, tip of the pen. This is more tapering here. And the fourth grade of arteriosclerosis is silver wiring of the arterioles, and this is associated with all the changes in grade 3 along with the silver wiring. All the veins are occluded. There's no blood inside now. So you see the empty blood vessels or the empty arterioles here. You cannot see any blood actually. This is or the veins are occluded now. So this is basically occluded blood vessels and the severe hypertensive changes. Hypertensive severe signs of severe hypertensive retinopathy. As I told you earlier, this causes changes into the disc, into the retina, and also into the choroid. The choroidal features are actually seen in acute hypertensive crisis. The patients who have got preeclampsia, sometimes they are referred from the OB/GYN department for fundus examination if the patient complains to them that he has got acute blurring of the visual acuity. So this is the one. Acute hypertensive crisis in these patients are sometimes the patients who have got uncontrolled hypertension, they present with malignant hypertension. So all these features come with preeclampsia and with malignant hypertensions. So this is acute. This is known as acute hypertensive crisis. This one along with the disc edema. In the first picture I showed you, first slide I showed you this picture. There is focal choroidal infarcts. These are known as Elschnig spots. Here, these yellowish lesions. This is subretinal lesions. These yellowish spots. These are focal choroidal infarcts known as Elschnig spots. And then this is fibrinoid necrosis along the choroidal vessels. This is known as Seeger's streaks. These are linear lesions, you know. They are along the blood vessel. These are focal, and see this one, these yellowish, these are actually linear lesions. They are along the choroidal blood vessels. And third one is the exudative retinal detachment. So very not quite infrequently when the patient is referred from the OB/GYN department for fundus examination, you see exudative retinal detachment. So this is acute hypertensive crisis. You see the retina is elevated and it has got all the features as we have read in the chapter of retinal detachment of exudative retinal detachment. So there is exudation, subretinal exudations, vessels from the choroid are leaking. So this leads to the exudative retinal detachment. Now these are the markers of preclinical systemic disease, the preclinical systemic hypertension. So sometimes you see the patient, the fundi of the patients, and they have got these features, and you need to refer the patient to the internist for the management of hypertensions. So what are the features? Number one, there is reduced retinal arteriolar caliber is an early pre-hypertensive sign. The second one is wider venular caliber is specific for impaired glucose metabolism. So this is actually for the diabetes. And then low arteriolar and high venular caliber are associated with preclinical cardiovascular disease. This we can understand. We have already discussed this one, arteriolar narrowing, and then we saw the different signs which we see in fundus examination in cases of arteriosclerosis. That is Salus sign, bonnet signs, and everything. This is what is that. And increased venular tortuosity can be associated with chronic hypertension and pre-hypertension. This is sometimes there is tortuosity and sometimes there is straightening of the blood vessels. Management of this hypertensive retinopathy is referral to the internist for the control of hypertension. Nothing else, no role of any lasers in these conditions, no role of any anti-VEGF injections. So this is very important to differentiate the features of hypertensive retinopathy and diabetic retinopathy, because the management is absolutely different. We need to treat diabetic retinopathy by ourselves, and for the hypertensive retinopathy, if it is not associated with diabetic retinopathy, we need to refer the patient to the internist. Thank you so much.